Hello and welcome to another Pypecast. Today we're going to talk about traumatic cardiac arrest. Traumatic cardiac arrest is something that we don't look at that often. Okay, despite our training being highly trauma-based focused, I mean, you guys at the school did more trauma than anything else really, but when it comes to cardiac, we tend just to fully focus on the ALS algorithm and not the considerations to do when you have cardiac arrest due to trauma. Okay, because it is very different. And for us, it's going to be more difficult and more things to consider because we're either going to be by ourselves or with a team. Okay, so we'll talk through the considerations of this, and then essentially it's up to you on the ground to decide which one takes precedence depending on the situation. Unlike the other algorithm, this one here is dynamic. You can shift your focus based on the kinetics. Okay, and you can do things concurrently if you have the actual personnel. So right at the top, we need to consider if this person has, non-reversible causes. Okay, so if you've got traumatic or a life-threatening trauma, so they're not quite in the cardiac arrest yet, but they've got injuries non-compatible with life. And as we know, we don't attempt resuscitation if that's the case. Total transverse, decapitation, that sort of thing. Now there's also situations during volatile combat that we don't attempt resuscitation as well, and that's just the nature of it. Okay, it'll be too resource heavy, too time heavy, and it'll put everyone in danger if you were to do it in certain situations. All right, so we're not going to talk too much about those ones either. Our considerations in life-threatening trauma don't change. Okay, we always start with catastrophic bleeding. We must control that using your tourniquets, using your packings, using everything you can to stop that bleeding. We need to maintain an airway, and we need to assess the effectiveness of breath, and if required, decompress the chests. You need to get IV access, and in the event that you can't get IV access, then IO is your point of call. We also need to consider the need for early damage control surgery and massive infusion protocol for bloods. Okay, so especially when you're on the ground or by yourself, you need to look at evac timings. Get them out. We want to prevent cardiac arrest as best we can. If somebody goes into cardiac arrest, or you find somebody in cardiac arrest, then it's slightly different. Okay, so if somebody, even though your interventions are in place, you've already done a bunch of these things, and they move into cardiac arrest, then you need to consider the probability of whether this is a medical cause, so a non-traumatic cause, infarction, electrolyte displacement, all the normal causes that we have for cardiac arrest. Is it likely to be that? If it is, so you've done all the interventions above, so you've ticked all the boxes for traumatic, then you just continue as we did before. But if it's not, then we need to do a few things before we start cardiac arrest, or in conjunction with cardiac arrest, but the things that we're about to talk about take precedence over CPR. So those things are, first and foremost, you need to control the bleeding sites. Have to. Okay, even though it's not written up there first, the airway one is, the biggest priority is to control the bleeding sites and to get perfusion into that person. Okay, first point of call, most of the time. Other things that need to be considered is you need to decompress the chest. Okay, so bilateral needle T's or finger thoracotomies. Sometimes, if you come across an unconscious casualty in an area where there's been explosions, things like that, and they're unconscious, it's protocol, especially with the TCCC, just to do bilateral needle T's, finger thoracotomies, depending on your training, and then keep looking for the rest of the problems. So, depending where you're working, that will become your first point of call. Stopping bleeding, getting perfusion, protecting the airway, doing needle T's, they're your top priorities when dealing with trauma. Okay, the most common arrhythmia when dealing with trauma is pulseless electrical activity. So you'll see some form of activity on the monitor, but they'll have no output. So the effect is on the output. Now, whether that's due to lack of circulating volume or tension pneumothorax, okay, doesn't really matter. We need to fix those problems first, because sometimes by fixing those problems, you can get ROSC. And with those ROSC, then you can move over to your post-resuscitative care without even doing CPR. Starting CPR in the presence of hypervolemia or tension pneumothorax is obviously futile. Okay, so because the probability exists due to the kinetics, we fix them first. Now, ideally, we put blood in these people. If you have blood, then you do 20 mils per kilo of blood. You start your massive transfusion protocol of 1:1:1 ratio, depending on where you're working, and you'll give them bloods. If you don't have bloods, then you substitute with crystalloids. Okay, knowing full well that because you're using crystalloids, they've got a decreased probability of actual survival. Not a no probability, but it's decreased. Okay, so you need to get into facilities that have blood pretty quickly. Once you're in a more advanced facility, okay, if you're not already, then you can start looking at things like ultrasound, things for pericardial tamponades. Okay, so you can do a pericardial centesis if required. Okay, you can also consider doing a clamshell. Okay, so doing a full thoracotomy, so you can get access to the heart, you get access to the descending aorta, you can fix the cardiac tamponade with your eyes as opposed to using ultrasound. But obviously this is something that we're not doing on the ground, and it's also something that we're not doing in our tents. Okay, this is often done in resus bays overseas when you have trained personnel that can do it. Okay, now obviously it has massive advantage. By clamping the descending aorta, you're encouraging all the circulatory volume to stay up in the lungs, the heart, and the brain. Okay, so you're encouraging what's left of the circulatory volume right there. As soon as you do that, then you move to internal cardiac compressions and internal defibrillation. So obviously you have the machinery for internal defibrillation, okay, because it's obviously different. Okay, so they're quite advanced practices, but sometimes are needed to be done and needed to be practiced. For us on the ground, all we need to do differently is consider the environment they're in, consider the trauma patterns that we have, look at protecting airways, massive infusion, 20 mils per kilo of crystalloids, whilst controlling every single bleed, even the little ones. So this is where you get your first aiders and CFAs involved to search the body for all external hemorrhage ports and block every single one, below the tourniquet or not. Block every single one. Consider the need for needle T's. Once you've done those, then you can start CPR. If you're in an environment where you have more people, then you can start CPR. You can attach the defib. Now I'd recommend not defibbing until the rest of those things we just spoke about are fixed. And also CPR does not take precedence to your perfusion control. So perfusion stabilization, hemorrhage control, and decompression of the chest. They take priority over CPR. Once all the reversible causes have been looked into, so you have good perfusion, the tension pneumothorax are fixed. Now obviously needle T is not good enough, it's a temporary fix, long term, usually needs IPPV involved as well, same as finger thoracotomies. Okay, if you put finger thoracotomies in, then you need positive pressure over the top in order to inflate the lungs. Consider the use for intercostal catheters, and that's a definitive fix. You can start CPR before the ICs are in place, okay, but don't think that needle T's in particular are a fix for the problems. They're a pseudo buy you time if they work. Speaking of needle T's, you may not have been taught it, but there's two sites. You obviously have second intercostal space, mid-clavicular, that's where you've been taught, but a universally accepted site is also the fifth intercostal space mid-axilla. Okay, so start practicing that, start trying to find that on people, because most of the time people go significantly lower down, and I mean 8th or 9th intercostal space as a thought. Okay, so start thinking about where that fifth intercostal space really is on a person. When all the problems have been fixed, so you've gone through everything that's written on this page and you still don't have ROSC, then it's reasonable to do CPR, ALS protocols for about 10 minutes. Once you've gone past that 10 minutes mark, then your probability for survival, low for starters, 7.5% from the start, has now reduced dramatically. Okay, so it is reasonable to stop CPR from there. Okay, now 10 minutes, what maybe in practice seems like a long time, but there's sometimes that people will be forced to do CPR for 60 to 90 minutes, especially when we're dealing with antithrombolytic administration. The expectation is that you'll do CPR for up to an hour and a half after that. So 10 minutes isn't that long, okay, but that's what the studies have shown us. If you get ROSC, then perfusion is your game. Perfusion is your focus. So you need to have a systolic blood pressure of 90 up to 110 if there's a consideration of head injury. So closed head injury can go up to 110. Okay, but that is your goal. Okay, obviously oxygenation, all that sort of stuff comes into place. You need to maintain that perfusion before they go into surgery. Okay. Now, a lot to look at when dealing with cardiac arrest due to trauma. Okay, there's a lot to think about, and it's nowhere near as clean as the other algorithms. Okay, because it's dynamic, there's lots to consider, and there's lots that need to be done. So this is something that you guys really need to practice with your team. You need to get it down to considerations, down to an absolute, and when you look at your H's and T's, think about your probabilities instead of going through starting at the start all the way down. Because if you start at the H's, work all the way through, by the time you get to tension, well, they're already dead. Okay, so think about probability of H's and T's and fix the probability ones first. If you've got questions on this one, there's plenty of research that can be done. The TCCC protocols are amazing for this side of the house, but I just put it out here for now for you guys to start practicing it, because it is woefully under-practiced, under-talked about, okay, where it should be one of our main considerations for cardiac arrest. Until next time, take care.